All right, welcome everyone. As people are coming in, I think we can get started. So welcome to our Canadian Guidelines for Post-COVID-19 Condition, or CAN-PCC webinar series. This is the second session for us as a CAN-PCC team here. And we're very excited to have you here today and to hear the presentations that are scheduled. Before I introduce our speakers, I first want to quickly introduce myself. I'm Dr. Robbie Newlaat. I'm the co-lead investigator of the CAN-PCC project, and I'm at McMaster University. And I'm happy to be your host or moderator today. And again, introduce the speakers and help with some questions and answering at the end of the session. So today we have some excellent presenters from our project's teams. They are Vinita Dubey, Thomas Piggott, and Chris Maddison. And together they will be walking you through the prevention of post-COVID-19 condition or long COVID recommendations from our CAN-PCC guidelines. So before we get started, I want to give a short introduction for the three of them. First of all, Dr. Vinita Dubey is a CAN-PCC Prevention Guideline Team member, and she's an Associate Medical Officer of Health at Toronto Public Health. Dr. Thomas Piggott is the co-chair of the Prevention Guideline Team and Medical Officer for the Halliburton, Kawartha, Northumberland, Peterborough Health Unit. He's also family physician and assistant professor at McMaster and University and Queen's University. We also have Dr. Christopher Maddison. He's our CAN-PCC patient representative on the guideline team that addresses the topic of neurological and psychiatric topics and questions. He's also an assistant professor in the Department of Computer Science and Statistical Sciences at the University of Toronto. So welcome to the three speakers. And I also, at this point, want to acknowledge Dr. Jessica Hopkins, who was the co-chair of the guideline team for the prevention of post-COVID-19 condition. Unfortunately, she could not join us today, but we really appreciate her work for this team and on the guidelines overall. Also, before we get started, as we always do, we want to provide the land acknowledgement. It's important to acknowledge that the work of CAN-PCC takes place across Canada, a land that is the traditional, ancestral, and unceded territory of many Indigenous nations. From coast to coast to coast, these lands are home to the First Nations, Inuit, Métis peoples, who have stewarded them for millennia, and we honor their rich cultures, languages, traditions, and histories. For our McMaster University presenters, we recognize that McMaster sits on the traditional territories of the Mississauga and Haudenosaunee nations within the lands protected by the Dish with One Spoon, Wampum Agreement. We can go to the next slide. And a final slide from my side, some reminders about rules and housekeeping for today's webinar. Please submit your questions using the Q&A feature in this session. While we'll try to keep an eye on the chat, the Q&A is your best way to reach us with your questions. Wherever possible, slides are presented in both English and French, as you can see. For more complex slides, we'll present the English first, followed by the French. A recording of the webinar will be available on the CAN-PCC website, which is canpcc.ca, a few weeks after today. So after these introductions, I want to again welcome our three speakers, and I want to pass it on to Vinita.
Okay, great. Thank you so much, Robbie, and thank you everyone for joining us. So we are going to go through the guidance on prevention for post-COVID condition. Next slide, please. Neither myself, Thomas, or Chris have any disclosures to declare. Next slide, please. And the objectives that we want to discuss in this session is to describe the appropriate options for the prevention of post-COVID condition, to share how the CAN-PCC guidance can be incorporated into practice, and finally, to increase awareness of the CAN-PCC guidelines. Next slide, please. So we know that post-COVID condition or long COVID is a relatively new and complex condition affecting different parts of the body. Next slide, please. It is a post-COVID condition or long COVID, as has been named by many in the public, usually appears within 3 months from the acute COVID infection and lasts at least 2 months. Now, symptoms can vary, and we'll go through them. They can change or they can worsen over time, and they can definitely significantly impact daily life. And it's estimated that around 400 million people have had post-COVID condition globally. Next slide, please. Now, CAN-PCC uses the definition from the World Health Organization, and that is the definition that we just described. So I just want to note that. Next slide, please. And we have talked about how this condition has had a very significant impact globally, affecting so many, 400 million people. Next slide. Now, the data in Canada is also available, and it does show through Statistics Canada that 1 in 9 adults, or 3.5 million adults, have experienced long-term symptoms after a COVID-19 infection. And 600,000 adults in Canada with long-term symptoms have missed days of work or school. So it's, even in Canada, has had a significant impact. Next slide, please. Now, the commonest symptoms are fatigue, pain, shortness of breath, brain fog, sleep problems, and post-exertional malaise. But there are over 200 symptoms that do exist. And so they could be cough, impaired memory, headache, joint pain, weight loss. I mean, 200 symptoms is a lot. And so it's very hard to characterize it in a nice, clean nutshell. But that is how we would define it. So I'm going to now turn it over to Chris to discuss his experience with this condition. So Chris, over to you.
Thanks, Vinita. So I'm going to start just by sharing 3 quotes from some long COVID patients, just to set the context, and then I want to say a little bit about myself and my experience, and what I hope the public and every patient and health professionals take away from these recommendations. So I guess starting with mine, and I'll expand on this, but I don't really expect miracles. What we want is the decency of medical research to answer this large-scale public health crisis. And we don't, from what we understand in the data, this doesn't seem to be going away. And there are very long wait lists for medical clinics. Some of the medical clinics are not well advertised, I think partly because there's such an overwhelming demand. And so there's a need for guidelines and for funding. Next slide, please. Oh, sorry, next slide, please. Oh, yeah. And then just to quote Kimberly, another CAN-PCC patient representative, she'd like to see clinicians consider these guidelines in this practice, encourage sensitivity with patients that are expressing those concerns, and would like to see the public use these guidelines to better inform and empower themselves in health decisions. So that's those are quotes from 3 patients that have been involved in CAN-PCC, and I want to take a moment just to sort of step back and tell you a little bit about my story and what I hope people take home from this. So I'm a professor, as was mentioned at the beginning, of machine learning at the University of Toronto. I contracted COVID in early 2022, and my life changed dramatically. So instead of participating in what has been one of the greatest expansions in the history of my field, I went from being an active academic researcher to being largely bedridden, struggling with severe neurological symptoms. And like many patients, I found myself in a medical system that wasn't really prepared to help me. My doctors worked hard to figure out what was going on, but ultimately I was left without a formal diagnosis. And I quickly realized that there was a lot we didn't understand about long COVID. And so that's why I got involved in CAN-PCC, because I wanted to help drive this field forward. And the context that I found myself in was sobering. Medicine has been historically blind to these post-infectious consequences of viral and bacterial infections for the most part. For decades, patients with long-term effects of infections have been pushed to the margins of medical research and practice. And when patients don't recover as expected, they are often left to navigate a fragmented healthcare system alone. And it's that systematic neglect that left us unprepared to deal with long COVID. And so that's exactly why efforts like CAN-PCC are so important, in that they represent our attempt to finally build an infrastructure and a knowledge base that we need. And I just want to highlight just the monumental task that we're facing, because we are trying to build an understanding of this disease basically from the ground up. So think about what that means in practice. Clinicians are learning to recognize new symptom patterns while seeing patients. Researchers are designing studies while still developing the tools to measure outcomes. Funding bodies are evaluating grants without established frameworks for what good research looks like in this disease. And medical schools are possibly trying to update curricula about a condition that we're even still struggling to define. It's as if we're trying to write the textbook, train the teachers, and educate the students all in the same semester. And at the same time, millions of patients need answers and treatments today, not years from now when we've built this perfect system. But I want to just say that we should not confuse this current struggle to understand long COVID with an inherent complexity in the disease itself. As we invest in research and build our knowledge base, what seems overwhelming today will become clear and manageable. The path forward isn't actually that mysterious. It requires the same dedicated scientific inquiry and resource investment that has illuminated other diseases through medical history. So I just want to close by, speaking to each of the different stakeholders in this process directly. To patients, I want to say, I want you to know that I have felt heard throughout this process with CAN-PCC. I saw so many people put a very genuine and heartfelt effort into these guidelines. They really aren't perfect and they aren't complete, but that's not because people didn't try hard enough. It's because we're still building the foundations that we need to study this disease properly. To the clinicians, I hope you understand that these guidelines are not the final word. You'll see a lot of recommendations with weak evidence ratings. That's okay. It's where we're starting from, not where we're ending. And what we know for certain is that long COVID is real. It can be measured in some cases, and the weak evidence ratings reflect this historical lack of research infrastructure, not necessarily the validity of what patients are experiencing. And then finally, to policymakers, we cannot treat these guidelines as mission accomplished. The US is putting $500 million into new trials now in the Recover TLC initiative, and we're learning more every month. And so the guidelines will need to be updated as our research grows and our understanding grows. So I just want to close by saying that, we shouldn't mistake a lack of evidence for evidence that nothing's wrong. When millions of people report adverse outcomes from an infection and we say there's no evidence, what we really mean is we haven't built the right instruments to measure it yet. And that's especially true for post-infectious conditions, which medicine has historically overlooked. So thank you, and thank you to the CAN-PCC team and all the patients that were involved in helping make this happen.
Thank you so much, Chris. I'll continue from here, and I think that was incredibly powerful, and appreciate your participation in the process, your story, and very much also want to echo the validation that you shared to people experiencing this. On a personal level, as a public health doctor and as a clinician and as a researcher that's been helping with this, I also have, as a public health physician, had to help to respond to the COVID-19 pandemic. I had a colleague die of COVID-19 early in the pandemic. I had people that I knew affected, including with long COVID, with post-COVID condition, including a close healthcare provider, a colleague who was bedridden for over a year and impacted. And I think very early on, those personal experiences helped me to realize that some of the dogma and teaching in my own medical education, including historically, as you mentioned, Chris, on other post-infectious syndromes, including experiences with Lyme as a specific example. I think I very early on realized that some of my teaching needed to be updated and that our understanding had evolved. And it's been a huge honor working with the diverse group of stakeholders in this process as we've developed guidelines. I'm going to, as co-chair of the wonderful group that Vinita is a part of, and we have a number of other panelists that were on the Guideline Team 1 Prevention group. I'm going to speak to our recommendations and a bit about the process that was used. The Public Health Agency of Canada graciously funded this work. It wouldn't have been possible without that funding to provide easily accessible and high quality guidelines on post-COVID condition and facilitate their use, the knowledge mobilization to multiple settings. We've led this from a McMaster University Grade Center and Cochrane Center standpoint, but it's actually been an incredibly collaborative, diverse group from across the country and beyond, with over 150 individuals helping from coast to coast to coast in Canada, coming together for this effort. We had divided the work into 6 guideline teams. They included, each guideline team included people with lived experience, allied health professionals, physicians, economists, researchers, nurses, public health professionals, a variety of individuals. And again, one of the critical pieces was really centering this work on the lived experience of people with PCC. And here are some of the patient partners who've been really driving this work and helping throughout. In particular, I want to acknowledge Robert and Jennifer, who participated in the GT1 prevention group. We sought to have balanced representation, engagement of key groups and collaborators, a transparent process, independent management of conflicts of interest, which is critical for trustworthy guidelines. And we had standardized training that helped to inform and level set the experience of everyone coming into the process. To develop the guideline, the final recommendations that are released, we selected and prioritized topics. We developed draft recommendations. We underwent public consultation and genuinely listened to this input and sometimes really changed in quite significant ways, and then finally released recommendations. We had a very important equity lens on the process, including representation, but also a research evidence synthesis lens of health equity for various equity-seeking groups. This was quite critical. And ultimately, across prevention, testing, diagnosis, pharmacological, non-pharmacological, neuropsych, peds and adolescent, and health system topics, these 6 guideline groups, we've developed or will have developed nearly 100 recommendations. So you'll hear today about the prevention ones. And if you haven't signed up for our other webinars on the other topics, really encourage you to check them out. As Chris mentioned, an absence of evidence or very low certainty evidence does not negate the importance of an issue. And it does not necessarily mean that we shouldn't be doing something. It just means that there is certainly more nuance that is needed in the recommendation. So you will see through here many conditional recommendations. That doesn't mean that people shouldn't be doing it, but it does mean that what we identified in the literature evidence out there was perhaps of lower certainty. The difference between benefits and harms was perhaps small, or the values of and preferences of people that the guidelines apply to may vary. And so it doesn't mean that people shouldn't do it, but it does mean that some people would not want to follow the recommendations. So a nuanced understanding and perhaps healthcare professional discussion is needed in implementing the recommendation. For a person seeking care, again, most people would want to follow a conditional recommendation, but many would not. So The first recommendation we're going to talk through is going to be on the use of vaccines. We've seen tremendous, unprecedented rollout of vaccination for COVID-19. Most of the attention to date, certainly in my field of public health, has been on the prevention of severe outcomes of COVID-19 for what we typically talk about as high-risk populations for severe disease. But what we wanted to consider in this guideline was, do vaccine doses, both primary series and additional doses, prevent post-COVID condition? The evidence was clear that they do, and there is a recommendation, a conditional recommendation for vaccination using the course series of a minimum of 3 months, but within the last 6 months, there is evidence if you've had vaccine, there is impact to preventing post-COVID condition. And when we look at the absolute impact, we see 16 fewer cases of post-COVID condition for every 1,000 people that are vaccinated. And that is a small but important difference that we identified. In this recommendation, we also considered both values and preferences and all of these other factors and criteria, including cost effectiveness. Generally, we know that vaccines are acceptable and feasible. And I think that this recommendation as a public health practitioner is becoming particularly important as there's a movement from change and provincialization of sort of vaccination programs that have for the last number of years been uniquely federally administered just because of the pandemic. And so on a continued basis, it will be really important for provinces to think about people who may be at higher risk of post-COVID condition, who may have had post-COVID condition before, and this recommendation applies for the general public for prevention of post-COVID condition. Ici en français. The next recommendation that we looked at was the use of face masks. This was obviously a very important recommendation, and the reasons were that we wanted to look at face mask use for the prevention of COVID-19 transmission. We know that a post-COVID condition is caused by COVID-19 infection, and therefore we wanted to look at prevention strategies across numerous settings and types of interventions. We looked at both healthcare settings in the community and out of hospital, as well as long-term care, residential home settings, and community settings generally. And we looked at the use of masking in these settings. We, again, here have a conditional recommendation in favor of masking for these populations, both out of hospital clinic settings, as well as long-term care settings, as well as in the community. You can see the evidence that we have identified presented here for masking, and the prevention per 1,000 individuals wearing a mask with a higher transmission risk level. We saw 17 fewer cases. So there obviously is low certainty evidence here presented, but there is an important difference favoring mask use for these settings. We know that there's a lot of variability, obviously, and acceptability, but it's feasible to implement. People's values around masking differ, but certainly when we look at masking, this is a helpful and important part of a multi-layer prevention strategy. On masking as well, I do just want to highlight that we looked at multiple kinds of masks. We found a small but important increased prevention benefit of a respirator or more tight-fitting mask. Respirator is elastometric reusable type mask. We also looked at the planetary health consequences of masking as part of this recommendation. You can check it all out on the CAN-PCC.ca website. Moving on to our next recommendation, this recommendation and the other underlying evidence is important to highlight because it actually, to me, demonstrated the therapeutic validation of post-COVID condition, long COVID, and that is the concept of therapeutic validation is if there's an effective treatment to prevent something, then that is evidence that this is truly a condition that very much exists. And I know for many of the people experiencing this, that's the case, but I'd encourage you to delve deeper into the evidence on metformin, because for me as a practitioner, this is a prime example of this concept of therapeutic validation. So when we looked at metformin, we knew that there were experimental studies that therapeutic doses of metformin have impacts on human tissues. It's a widely used medicine for other conditions, including diabetes. There is demonstrated activity against SARS-CoV-2, including reducing oxidative stress and inflammation. And we know that earlier initiation seems to have larger effects, which supports an antiviral mechanism for its action in the post-infectious period to prevent post-COVID condition. We had a low certainty of the evidence and ultimately made a conditional recommendation in favor of metformin for the prevention of PCC. This applies to people with a new COVID-19 infection. And in the study, they were looking at people who had had symptoms for fewer than 7 days. The primary trial that this draws from, Bramante 2023, had a inclusion criteria of people 30 to 85 with a BMI of over or equal to 25 or over or equal 23 for those identifying as Asian or Latino. And the duration of treatment is a short course of 10 to 14 days of metformin. We know that you can see some side effects of administration, including gastrointestinal, but a lower dose can be helpful. So we definitely saw an important effect, one of the largest effect size we saw, a moderate benefit of metformin for the prevention of PCC. 41 fewer cases of PCC per 1,000 people with an infection that were initiated on metformin within that period, that 7 days after a COVID-19 infection. This shows, this example also, this recommendation also shows the interplay of some of our recommendations. Access to testing is important. We know that access to COVID-19 testing has become more challenged as PCR testing is less prevalent, and even rapid antigen tests are less publicly available across the country than they had historically been. And this is a challenge for this recommendation, because without access to testing to confirm if somebody has COVID-19 infection, it is a challenge, obviously, to initiate a treatment like this for providers. But this is really important. And if you take away nothing else as a clinician, think about metformin for this group of individuals. There's also a recommendation for people with PCC to be considering metformin with repeat COVID-19 infections. And so this is a really critical recommendation. I think that if you take nothing else from the recommendations we talk about today, think about this one, please. We ultimately saw that it would be probably be cost effective, that it's generally an acceptable and feasible treatment, and would be easily accessible and inexpensive from an equity standpoint. The next intervention we looked at was nirmatrelvir-ritonavir, sometimes known as Paxlovid, and the treatment of people with acute COVID-19 infection to prevent PCC. Our group also, here it's very low certainty, but we do have a conditional recommendation in favor of using nirmatrelvir-ritonavir. And the nuance in this is lengthy, and I'd encourage you, especially as a healthcare provider, to have a read on the remarks online. Ultimately, we were looking at trials in individuals 18 years and older, and had a mix of people vaccinated and unvaccinated. When we look at the evidence, we saw a small benefit, so 5 to 12 cases fewer PCC per 1,000 people with COVID-19 infection that were treated with nirmatrelvir-ritonavir. Ultimately, the cost effectiveness was probably favoring the use of this intervention, but the resources are important, large costs, and we know generally across the country at the present time, there is big access challenges because of the cost and the public coverage that generally does not exist for the population here for this medicine. I also would like to spend some time highlighting the COVID-19 Rec Map. It is the online platform that you can visit if you go to CAN-PCC.ca. We'll have a QR code coming up a little bit later. But the Rec Map is a one-stop shop platform that shows all of our recommendations. When you visit the Rec Map, if you go to CAN-PCC.ca and go to recommendations, you will see this landing page that has a map that shows the number of recommendations by grouping of the type of intervention, which is grouped by our 6 guideline groups. If you click on the guideline group, you can see mask, metformin, et cetera, within the subgroups and by population. And so you can see adults, public, et cetera. And if you click on that as well, you can see subpopulations. To see the actual recommendation, you can either click one of these boxes and it will highlight the applicable recommendations for that group, or you can search, or you can go up here to the recommendations list bar at the top. I'd also encourage you to check out all of our recommendations are obviously being translated into French, as well as plain language recommendations are being generated for members of the public for clear, actionable recommendations for folks. The plain language recommendations summarize the same information, but they use more accessible language and a one-page view. So it might be better for individuals to start here. And if you're interested, you can delve into the full recommendation and all the underlying evidence, which can sometimes be a bit more technical. Finally, on resources, we wanted to highlight some other key resources. You're joining this webinar today or watching the recording online. We also know that we'll be developing infographics and online resource sheets coming up. And I'd also suggest that you check out, if you haven't already, the customizable self-management tool that's available on the My Guide at longcovidguide.ca. For healthcare professionals, we have healthcare professional tailored CME accredited webinars that are being run by the University of Saskatchewan colleagues. There is going to be a 2-hour course that will be offered, as well as a series of webinars. And there's also a training program that'll be available through EBM Connect Canada. We are looking forward to and excited for questions about any of our work, our recommendations, any of what I presented today. I will just show, obviously, CAN-PCC.ca, like I mentioned. Upcoming webinars, you're here today on the 6th. You'll see we're having one in a couple of days on diagnostics. And you can follow all of our info and join our newsletter here. I'll leave that QR code up for a moment. The next slide just has a feedback evaluation on the webinar, which we'll come to shortly. And I have a couple of slides on our references, but we look forward to questions and discussions from the audience. And thanks to the co-presenters for helping today. And I hope this was helpful to the audience joining or those watching online. Merci à tous. Merci beaucoup. Je pourrais prendre les questions en français aussi et traduire pour la groupe, mais I look forward to any questions there may be, and I think I'll turn it back to you, Robbie, to help to facilitate for us. Thanks.
Great. Thank you very much, Thomas, Vinita, and Chris. Very nice, clear presentation. So we have 2 questions right now, and of course, everyone else, please feel free to add more to the Q&A feature in the platform here. I'll read them out, and I hope our presenters and maybe other experts that are joining us here can help us answer this. But first of all, I'm going to look at our presenters, of course. The first question is, can you speak to why NACI, so the National Immunization group is dropping to once per year for vaccines. Thank you. Who wants to take it on? Go ahead, Thomas.
I can start. Yeah.
Okay. Go ahead, Vinita. That makes sense.
So just to note, I am a member of NACI and am vice chair. And so, NACI just recently posted their tried to be a bit more longer term in terms of recommendations for COVID, where they, it's challenging. We have not seen seasonality with COVID, but we are in the place where we are post-pandemic and we have this endemic illness. So part of the guidance that came out looked at recommending a traditional fall type booster for essentially everyone who's 6 months and older, and then recommended an additional dose for those who are at highest risk. And so that was the guidance. The NACI guidance doesn't delve in deep on the role of vaccinations and its impact on post-COVID condition. That was actually one of the reasons why I wanted to join CAN-PCC, to look into that a bit more. So the guidance is more broadly, like it's also to prevent hospitalization, severe illness, but also with the lens more broadly for COVID. So it's not just a once, it's once for most people, and then for the highest risk, it's a twice a year vaccination recommendation. Now, that being said, I just want to say one more thing, that the federal government has been sourcing the vaccine up until now, and for the next cycle, it will be up to the provinces to purchase the vaccine and to fund it. So we'll also have to see, despite NACI's recommendations, what each province makes eligible for their residents.
Thank you, Vinita. Thomas, you want to add to that, or?
No, I think that's great. No, that was great. Yeah, thanks.
Great, thank you, Vinita. And this also illustrates, of course, the many different perspectives we have involved in our project. And this is, of course, a great perspective to have included for this team from the immunization group, the NACI group. So thank you, Vinita, for providing that. Really important to have diversity of perspectives when you develop guidelines. So there is one more question. I think it disappeared.
We did just answer, Robbie.
Yeah.
I tried to answer it in writing, and I was going to say we could do it live too, but maybe I could take that if you don't mind. There's a question here from Dr. Hergy. To put the 16 fewer PCC cases per 1,000 vaccinated, what is the baseline risk of PCC in the unvaccinated population? So we used 3 baseline risks to assess through the process: a low baseline risk, a moderate, and a high level. And the recommendation and the point estimate of the absolute effect of 16 was based on a high risk level, which was 10%, or 100 per 1,000. So that was a guideline discussion and decision around that, and there was a scoping review and underlying systematic reviews on baseline risk of PCC generally. So we looked at a range of scenarios of baseline risk, and the 16 per 1,000 is based on the 10%, or the 100 per 1,000. Thanks.
Thank you, Thomas, for answering that question. The next one is, will Cochrane Canada be on Blue Sky? Many COVID-19 conscious professionals and researchers are using this platform to share their work instead of other social media platforms. Thank you for your work. I think on behalf of the central team, I can probably answer this and say thank you for the suggestion. We are not on there. I don't think we've explored that yet. So again, thank you for the suggestion, and we will look into that and see if we can also have a presence there. we're trying to get our messages out as broadly as possible, and so that's a very helpful suggestion. Then I will go to the next question. Given that the most prevalent variant of COVID-19 in Canada causes less severe disease and less hospitalization since prior variants, initial COVID-19, is the less post-COVID, sorry, I'm not sure if I understand this one. Let me look at it again.
I can help if you want,
go
Robbie.
ahead, Thomas.
Yeah, and I'll be curious for Vinita's thoughts, because I don't think we fully know. The evidence is still emerging on how the baseline risk, or how the risk of getting post-COVID has varied over time. We certainly know that a bulk, but not all, of people in Canada who have experienced post-COVID condition have experienced it for a while now, right? And actually, first were infected possibly before vaccination, possibly with the earliest variants of the disease and more severe disease. But we also are seeing it with people who have not had severe disease and have had post-COVID, have had COVID-19 infection more recently. So the relative proportion is hard to say. I think the guideline panel thought there was a general lower risk of developing new post-COVID condition if you hadn't had it before with more recent infections, but it's definitely not an absolute piece. And I'll see if either of my co-presenters or anyone else wants to share. Chris, Vinita?
Yeah, I mean, I think it is an interesting question, right? And I think that once we had Omicron, like less severe COVID, you know, do we even need to be vaccinated? Was a common question, for example, from where I stood, like being on NACI. Well, and I think we have to think about it in a number of ways. So one is less severe infection. Does it lead to less opportunities for post-COVID condition? I don't think we've answered that. And with the changing variants, it's really hard to keep up with that. And we've seen with the PCC literature, it's actually very hard to quantify that and keep up with it with the ongoing variants. What we do, though, tend to know is that if you've had more severe illness, you may be more at higher risk for more PCC. So preventing that severe illness, that hospitalization, especially among the high risk, is important. But what we've also seen with PCC and its prevention is there aren't particular risk factors to say who is more likely to get PCC and to be more likely to be prevented. And that's why actually, I think it's really important from a broader perspective. You know, we see that women are more likely to get it, maybe even at a younger age. And so understanding what we can do to help prevent getting COVID and getting, more importantly, PCC, sometimes means considering all of the options and what may be right individually as well.
Great, thank you, Vinita and Thomas, for answering that question. Making sure, I think some are answered also in the chat here, so let me just double check. So the next question is also for our presenters. I have got COVID-19, so the person says, I have got COVID-19 for the last 3 years. Each time I have come from Greece, England, and Ireland. With the last bout, I developed pneumonia. When may I get the next COVID shot, as I have had 7 vaccines already?
And I can take that. The recommendation is, at least in Ontario, in terms of eligibility for vaccination, is you can get it really anytime if you haven't had one yet this cycle, like from the fall. But if you've recently had COVID, you can wait 6 months to get your next dose, or a shorter interval of 3 months.
Thank you, Vinita. Then the next question, or it's a comment actually, and we can respond to that as well. People are having trouble getting their doctors to prescribe metformin because this recommendation is low. Even producing the recommendation, doctors won't prescribe. I think this gets sort of to the heart of what we call our knowledge mobilization efforts, which is a really important part of our overall project, which means we not only develop our recommendations, but we develop tools and activities to disseminate them and have them taken up in practice, which means we have to be very clear in how we explain what the recommendation means. And others can add to this, but I think the main message here is that we need to do the best we can to communicate what that means, certainty of the evidence, as well as what a strong and conditional recommendation is. But also, doctors need to be open to learning about that. So if you come with that information to them, hopefully they are open to learn that it means if you have a strong recommendation, that basically means that you would apply it in most patients, basically all patients, with a few exceptions. However, the reality for CAN-PCC is we have a lot of conditional recommendations that are either based on low or what we call low or very low certainty evidence. Conditional means that it is, so we do suggest to use something, but really an important part of that is you should discuss it with the healthcare professional or your doctor. Because if there's the evidence is of low or very low certainty, as Chris and some of the other speakers have mentioned, the evidence is developing as we go. We're sort of trying to build it as we go. We're often not that certain about what the evidence indicates. Still, we provide guidance on what to do. We suggest what to do. But again, this can be discussed then with your healthcare provider. And that should be the main part of it. You should look at, okay, what is in our recommendation? What is the evidence supporting it? And then based on your values and preferences, which also come into play, you can then make a shared decision. That is the intention of a conditional recommendation often. And again, this is also on to us that we need to explain what that means. We need to make our tools as clear as possible. And with your feedback, and we are co-creating with patients, with providers. So we're doing our best, but we can always do better. So if you think some of our tools could be clearer in that sense, please let us know and give us that feedback. That's the main thing I want to say about that. Thomas, if you want to add anything, please go ahead.
No, I think that's great, Robbie. To your point, we're doing a lot of work on knowledge mobilization to get the word out. I think Chris very eloquently spoke earlier to the fact that the research field's emerging, and we're dealing with a condition that previously, did not have a significant understanding. It takes time to have that trickle down to change practice. I would also encourage all of you to be agents in that process. If you're here and listening today, share with friends, colleagues, share with your providers, help to, even navigate CAN-PCC with them. You can share information like what is here. I think the key on a conditional recommendation is that most people would still want to follow this recommendation. Majority, most. Many would not, but most would. And that is the distinguishing feature. So we think that this is an important treatment that needs to get out there, that needs to be accessible, that providers need to be providing, especially for metformin. We saw a moderate, the highest effect size of other prevention interventions. So I think we need to continue to work on mobilizing the public and healthcare providers around this. It was a lot of interest when I went to providers I've spoken to so far. Just last week, I did a webinar with healthcare providers in Nunavut, and there was a lot of interest, lots of questions, but lots of openness and willingness to think differently about a medicine that's been used in other ways, in other contexts, and may be helpful to improving health for this population, this group of people.
Thank you, Thomas. All right, so then we have the next question.
Maybe Robbie, sorry, if we could take the question in French. I don't know if you'd like me to answer in English or French, but we could take the question in French just for clarification. And the recommendations are all translated online, English and French. But c'est la question de Dr Gagnon. Et c'était, si je comprends bien, il serait adéquat de prescrire la metformine en prévention de la COVID longue à tous mes patients atteints d'une infection aiguë de COVID-19. Je travaille en clinique et en milieu hospitalier. Alors, ici, je vais commencer en français puis traduire en anglais. Les données ici, ça vient de la Bramante 2023 étude, et c'était dans une population spécifiée de les personnes qui sont 30 ans à 85 ans, qui ont un BMI un peu plus grand, puis aussi il y avait un plus grand effet, un petit peu plus grand effet dans les femmes que dans les hommes. Alors, je pense que ça doit prendre un peu la connaissance clinique pour savoir si c'est une bonne intervention pour ton patient, mais c'est probablement pas toutes les personnes qui ont une infection COVID-19 aiguë. C'est probablement un peu plus spécifié de ça. So in English, the question is, so should we be recommending prescribing metformin for all people with COVID-19? And you can see in the recommendation, there's some remarks and nuance because the trial, the Bramante 2023 trial that the evidence was based on is based on a focused inclusion group of people with age 30 to 85, BMI 25 plus. There was also a slightly higher risk and slightly more beneficial impact in women than men that was observed in that evidence. I think it's for clinicians in front of them. If you think your patient is at higher baseline risk of COVID-19, and definitely if they meet that kind of inclusion criteria, those groups, slightly higher BMI, more middle age, not young, older, it may be worthwhile prescribing, but the intervention is also fairly safe. I think that's important too. And Robbie, I don't know if you want to go to the question on more serious adverse events on metformin next, but yeah, I hope that helps. Merci, Dr. Gagnon.
Thank you, Thomas. Okay, yeah, so this is the next question perhaps then. What are examples of more serious adverse events with administration of metformin for prevention of PCC? Yeah, go ahead, Thomas.
There were two studies that reported on adverse events, the Reese study and the Bramante study. And there was very low certainty evidence around that, very few individually. The adverse events were abdominal pain and diarrhea, and the more severe related to, sorry, I'm just pulling this up, related to as well some extrapyramidal symptoms and somnolence. And so generally, clinicians probably have a lot of familiarity with prescribing metformin, not only for diabetes, but also, you know, conditions like non-alcoholic fatty liver disease and PCOS. So the group said that these were small, undesirable effects, not trivial to none, but that they were quite small, and estimated at 4 more per 1,000, but very imprecise, crossing kind of the 0 threshold, 11 fewer to 28 more. So I hope that answers, but it's a good maybe opportunity to highlight. If you go to the rec map and you look at the recommendation, all of that and the panel commentary around the undesirable effects is all transparently available under the metformin recommendation. Thanks.
Thanks, Thomas. That's great. And indeed, look up the details on the recommendation map on the website. And there's also a plain language recommendation with that. They are being provided as we release our recommendations. So if that perhaps may be clearer or may be better to also take to your physician, for example, this may be helpful. So it's a plain language summary or representation of the recommendation and the underlying information. Okay, so we have another question related to vaccination. So back to the Nazi change in guidance. if these recommendations are to continue with vaccines every 6 months to reduce the risk of post-COVID condition, how do you marry that with not being able to get access except once per year for the general population? The new NACI guidance also reduced the definition of who is high risk by quite a bit. Vinita, you want to maybe address this?
Yeah, so I think it's, again, I just want to reiterate that the NACI guidance looked holistically at COVID and COVID vaccinations, not specific to post-COVID conditions. So I just want to note that in terms of the guidance. And I think that this is something that we're going to need to watch in terms of what will be the public eligibility and funding for COVID vaccines going forward. I think if you look at the evidence that was reviewed for vaccination, it shows a benefit of, vaccination and reducing the impact of PCC. But there certainly is nothing in the evidence that we reviewed that, suggested, a Q6 month vaccination schedule to prevent PCC. Again, these are some of the gaps in what we have available in terms of the evidence. Some of the guidance from NACI was related to the fact that we still do see the broadest spikes in COVID infection in the fall, usually in the fall and beginning of the year, and in the spring and summer they tend to be lower. Not a true seasonality, so that's also part of it, is to marry it with the epidemiology as well. But again, the NACI guidance was not like once now for the next 10 years. It was really till 2026 with, looking at it and providing revised guidance based on updated evidence as it will be available.
Thank you, Vinita. And perhaps we can take the last question before we wrap up the session. So the question is there any evidence of how soon after infection someone will develop PCC or long COVID? If they haven't developed symptoms in 3 months, are they in the clear, so to say?
I don't know, Chris, did you want to take a first response and then we can, I think that this is evolving, but what are your thoughts on that, Chris?
I don't know if I have a great answer. I guess I would just say that at the moment the disease is defined clinically, and whether or not that captures one disease or many is still an open question. So I think it's a very hard question to answer, and I think as you extend the amount of time that you're allowed to sort of capture PCC patients, so if you say anyone who develops symptoms 6 months after a COVID infection, you're naturally also going to capture people that don't have what we will eventually call PCC. So I think it's a very hard question to answer. It's a moving target. I hope what will happen over time is that we take this big clinical entity called long COVID or PCC and start decomposing it into more tractable subpopulations with disease targets that we can go after for treatment. So I don't know if I have a definitive answer for you today. That's what I would say.
Thank you, Chris. And indeed, there are different definitions of what is considered post-COVID-19 condition right now. There are some differences between them. So we are still, let's say, figuring out the exact definition and the exact characteristics of what we would call post-COVID-19 condition. So I understand that it's not that easy to answer. Okay, we're almost at the time here. Thank you, everyone, so much for joining us today. Please don't forget to visit our website, so CAN-PCC.ca. We have more webinars coming up, as Thomas has showed before, so please stay tuned for that. You can see here the QR code to give us feedback. We really would like to get your feedback regarding this specific webinar, so please fill in the survey so we can keep improving and doing better at these sessions. And of course, I want to thank our presenters for today, Vinita, Thomas, and Chris, for your great presentation, as well as availability to answer these questions. Thanks, everyone. Very much appreciated. And thank you, everyone, for joining us. Take care and have a good day.